I work in Argentina, in Buenos Aires, with all these people, and we do all kind of interventional procedures. I'm talking about spine procedures. We do the whole bunch of interventions to treat pain. Among all the different sites of vertebroplasties, the pelvis, the sacrum and pelvis, accounts for the 2.3% of all the fractures we've treated. An insufficiency fracture is the effect of a stress, a normal stress, in an abnormal bone. And this is the case of the sacral insufficiency fracture, where the body weight acts in both sacral alas and break them. So we can see a line, a vertical line, parallel to the sacroiliac joints. Sometimes it's bilateral, sometimes it's unilateral. In the nuclear medicine, we see this H shape or the Honda sign. On CT, we can see the disruption of the anterior cortical of the sacroiliac. It's very easy to see it on MRI, but it's very easy to overlook just because the standard examination of MRI for spine is the sacroiliac are outside the field of view. And the factors that predispose this condition, this weakness of the bone, are osteoporosis, pelvic irradiation, prolonged corticoid treatment, rheumatoid arthritis, myeloma, Pelviplastia, budget, and hyperparathyroidism. Well, sacroplasty is wide way. It's a very well established procedure, and it can be done in the short axis or the long axis, parallel to the sacroiliac joint, and even with under CT. The results for sacroplasty are very good. They can reach more than 50% reduction in the mean visual and allergic case score immediately, and gradual more than 80% in 2 weeks or 90 in 1 year. This ring-like anatomy of the pelvis and the forces, the shearing forces acting in this area, may be responsible for occurrence of more than one pelvic fracture. The sites of fracture in the pelvis are first the sacroiliac and then the pelvis, with the body of the pelvis and the pelvic rami, the iliac plate, and the supraacetabular region of the iliac bone. So the initial mechanical failure is in the sacrum, and then it's transmitted to the pelvic bone. And with this unstable ring, could delay the healing of the fracture. And this is the case of the pelvic fracture. So the clinical presentation is a progressive groin and hip pain. We can see on X-ray longitudinal fracture lines on the superior and inferior rami, or in the body parallel to the surface. The treatment of the management is conservative and bed rest, reduce weight-bearing activity, and we know that is very dangerous in elderly people. And the majority of the patients become pain-free within 1 year, and sometimes it could be longer because of the development of non-union or cellular process formation. In a series of 286 patients treated with conservative treatment, they had 13.3% mortality. Instead of patients who are before the injury. Well, this second data is kind of tricky because of the age of the patient, but the first one is important. Pelvic arthroplasty has been described by Dr. Alexis Kalakis and some other case reports. And it's a procedure that we have to be aware that we have to gain access in a long and very thin bone, we have to go to the superior and inferior rami.
Maybe?
And with the patient in the prone position,
Knock yourself out. It's a real one. Yeah, like yours was working.
No, with the C-arm in the opposite
Look, we're
oblique,
trying to
we look for
decontaminate.
this
You don't
eye to
decontaminate by
target.
contaminating further. What the hell is all this?
So here we have the eye that we target for the superior with our needle.
Toxic boosters. Yeah,
And in the case
baby.
of the
It's got pheromones.
inferior
All right, I got a bottle of
we
it. Hang
go
them up all over
to
the
the
place.
same
Won't be able to
lateral,
resist.
I mean oblique, I'm sorry. And then we go prion to go all the way and have just one eye to target.
I don't know. Let me say,
This is the needle and this is the target we go. Well, this case is easy because we don't have a femoral head and we don't have a, it's a very thin patient, but we have to follow the needle in different planes, and we can see, it's like vertebroplasty that we have the target, the pedicle. Well, this is just a longer pedicle. This is a real patient. If this is the eye we target, and this is the needle going with the inferior rami. What we do is to inject just a little bit of cement, and then we put the stylet of the needle, and we throw the needle while we are pushing the stylet.
yes.
This is another case of we see that we treat both sacral ala and both the superior and inferior rami of the left pelvis, some leakage of cement and air during the injection, and this is a sagittal view with the cement within the both ramis. While reviewing the literature,
Wild animal.
what I saw is that all literature that they talk about pelvic fracture, they mention the relation between the sacrum and pelvic fracture. So they go from 39% to 78%. I mean, from the sacrum patients that present with the sacrum fracture, they present 41% pelvic fractures. And in our series, we have 31%. But it's curious that in the sacroplasty series, they don't mention pelvic fractures. I assume that maybe it's older literature and the sacroplasty didn't see. And as I mentioned, that the pelvic fracture is a consequence of the sacral fracture. Maybe sacroplasty could prevent that fracture. But anyway, I think that when we see a sacral insufficiency fracture, we must rule out the pelvic fracture. This is a safe and treatment and follow up and to look for indemnity of the cement because maybe we are talking about these shoring forces, maybe we're going to need another kind of cement or devices. Thank you.
We have a question, I suppose this is better for Kieran, is how do you code for these cases? Interesting, nobody at the podium practices radiology in the U.S. anymore. We have an Argentinian, Alsatian, an Italian, and a brother Italian. I guess I'm Canadian, and you're Greek. So the question is, why do U.S. practitioners code osteoplasty, procedures, sacroplasty, etc. outside the spine? Currently, no coverage from CMS. When do you think CMS will cover sympleplasty? I can't answer that. Does anyone in the audience have an answer for this?
If I may add, we had the same question this morning with Sean Tatton, and he says he codes for biopsy, and he does it for free.
That's it. Yeah. I was going to say that, and the benefit then for us is, I'll ask my question in a second, but related to that is because of the lack of reimbursement, the patients are coming our way. So of course we then have to code for biopsy and do it for free and hope that in the future when it comes to discogenic degenerative disease or the other spine-related procedures, instead of conservative management? Do you have to talk? Do you have to market your services? Do you have to let the orthopedic surgeons and the people who see these patients primarily know that you can do osteoplasty?
We have clinic, and well, at the beginning we just have the patients from referrals, but right now they come, for other patients, and I see the patients in clinic, and if I find that it's another kind of fracture, I go and treat it.
Thank you.
Bypassing a traumatologist.
If I may add one more thing that Sean said this morning was that if you can code for orthopedic codes, if you work with an orthopedic surgeon together,